Hello, everyone, and welcome to today's webinar, Co-occurring Treatment Considerations for Adolescent Substance Use, led by Libby Beer, who is the Director of Substance Abuse and Recovery Services with the Northwest region of ERISA Health. My name is Anna Kate Bogarts, and I'll be your webinar moderator for today. Before we get started, I wanted to let you know a little bit about the ARBEST program and do some quick housekeeping. Arkansas Building Effective Services for Trauma, or ARBEST, is a state-funded program at the UAMS Psychiatric Research Institute. And our aim is to improve mental health services for children and families who have experienced trauma. We work closely with multiple partners, such as ERISA Health, to build a more trauma-informed state, and we're probably best known for providing training to mental health professionals on treatments that are effective with helping children and families recover from trauma. So just a few housekeeping announcements. If you have any questions during the webinar, we encourage you to type those into the question box that you should see at the right of your screen. You can put those in throughout the webinar, and we'll take time at the end to get to as many of those questions that we can. Also, if you're interested in earning a CEU or in getting a CEU certificate for attending this webinar, just make sure to stick around to the end, and I will give further instructions on how you can make sure you get that. We are recording this webinar, and we'll upload it to our ARBEST YouTube channel. We've also put our previous webinars up there for you to see if you'd like to see that. And finally, don't forget to check out the ARBEST Facebook page and like us. That's where we frequently post upcoming webinars and training opportunities and other resources. So make sure not to miss that. And with all of that out of the way, I'm going to turn it over to Libby.
Thank you. Good afternoon. I guess we've made it to the noon hour. Thanks for joining us. I'm honored to be a part of this. So I'm just going to go ahead and jump right in. And I will say at the beginning that some of these slides are pretty dense, and I do that intentionally in trainings like this so that you can listen along and not have to take hopefully as many notes. So the title here, Co-occurring Treatment Considerations for Adolescent Substance Use, is really long, and I considered just everything you need to know in starting working with clients with substance use, and that title didn't sound any better. So I know that some of you guys may already have some experience, and so I'm hoping that at the end we have some time to just have some good conversation. I'm sure there's some other experts on the call that could offer some great suggestions and pointers for us. So for today, I'm hoping just to kind of be our host for some good conversation at the end. Here are our training objectives for our hour together. I'm hoping that you become more familiar with a co-occurring treatment approach. Many of us on the call are licensed professionals working with mental health, but I'm hoping that you can understand some more signs and symptoms of substance use, learning the risk factors for substance use in our adolescent population, and then exploring some treatment considerations of complicating factors, in particular some of the trauma that many of them have experienced. So why is a co-occurring approach important? This is where if we were able to all be in a room together, or we had our microphones on unmuted, we would be able to have that conversation here. But I want you to just take a moment and think about, why is that important? Why did you choose to be on this call today? And I think it's really important that we understand that, because it can be a really important thing to even talk to our clients and their families about, understanding why we need to be asking the questions that we do and screening for substance use, as well as treating those. And so here are some of the benefits. Of course, this isn't all of them, but things that came to mind for me as I was putting this together is that untreated symptoms of mental health can lead the client to continued use, and untreated substance use can also affect the mental health treatment. There are research studies out there that show that it makes it even ineffective. And in order to provide appropriate and adequate care, you need to be able to identify the differences between those to either rule out or rule in, is this mental health? Is this depression? Is this trauma? Or is this depression and trauma and substance use? And how do you know the difference between those? So I'm hoping that I'm able to bring some of that more clarity for you guys today. And then learning some skills to provide co-occurring care to adolescents is, my hope is that it brings hope, is that you are able to instill that hope into the youth that you're working with and to their family, that by addressing both of those things, they'll get to a place of optimal wellness with their goals. So here are some statistics. I'm going to kind of go through some statistics on trauma. I'm going to go through some statistics on mental health and substance use, and just kind of seeing all of that prevalence together. So we just kind of have this foundation, working foundation and understanding together. And of course, you guys all know that statistics can vary from research study to research study. And of course, it can be really challenging the last couple of years to get some accurate information. So I did try to get some newer rates out here. 1 in 4 children or adolescents have experienced at least some type of traumatic event before the age of 16. Community samples across the U.S. were showing more than 2/3 of the children experience a traumatic event by age 16. And then 39 to 85%, that's such a broad range there, have witnessed some type of community violence, on 25 to 43% exposed to sexual abuse. And then 1 in 5 high school students reporting bullying. And I know there's so many other things in trauma, but just kind of getting you to start thinking about some of those trauma rates. And then here's some substance use prevalence rates. So early drug abuse correlates with substance abuse problems later in life. I'm going to talk a little bit about the brain and how that comes to be when we introduce drugs into a developing brain, how that does often correlate with a higher risk for substance use problems in the future. About 9% of 8th graders have used some type of illicit drug in the last month, and more than 21% of 8th graders have tried an illicit drug at least once. And then more than 8% of 12 to 17-year-olds report using drugs in the last month. And then of those, nearly 84% reported using marijuana in the last month. And by the time they're in 12th grade, roughly 47% have tried illicit drugs. I think this is also an important one because we are, fighting here in Arkansas a lot of fentanyl use and opiate issues as well. And so here we see a number of 4,777 Americans aged 15 to 24 died of an overdose of illicit drugs in 1 year. And this age group then also accounts for 11% of overdose deaths. And then I did a little bit of research because I felt like that number was getting higher. I've been in the field since 2004. And so kind of going back and found some older numbers, and that's 4 times the number, the rate from 1999. So with that same study from this past year, their key findings was that 61% is how much drug use had gone up in 8th graders between 2016 and 2020. 62% of teenagers in 12th grade had abused alcohol, and 50% of teenagers had misused a drug at least once. And then if you look at this other graph, I'm not sure if you can see all the detail here, but the dark blue, the first column is 8th graders, that green is 10th graders, and then that kind of a smoky gray is 12th graders. And you can see across there the lifetime, the past year and the past month, how we see that increase in that alcohol abuse. I also felt it important to talk about the considerations during the pandemic and how that's impacted our youth. I think that we're still just in the beginnings of understanding that. The brain wasn't prepared for the levels of chronic stress that they were under. This was not just a weekend of stress. This was long, drawn out stress. So I'm just going to kind of put some of those things into perspective. There was a loss of social time, which we know is critical in their stage of development. There was isolation. So when you're adding mental health issues, some maybe substance use issues that were already present, or if it wasn't, this is certainly going to create an environment conducive to some substance experimentation, use, and abuse. Also, boyfriend and girlfriend breakups. I put this in here. They already feel like it's the end of the world. I think we've all worked with a teenager or maybe have one of our own, and I mean, it is the end of the world for them. It's part of their development. It's part of where their brain state is. And so if there was a boyfriend or girlfriend breakup during the pandemic, just took that to the nth degree. And the over and over the P word, the pivots. Back in school, then at home, back to school, then at home, and not sure if that was, a safe place or not physically, let alone emotionally. And then many of them were experiencing or were fearful of financial, housing, and food insecurities, their family's health. Maybe they were experiencing COVID in their homes and were concerned that there would be exposure, that just the fear of the unknown, whether or not their family members that are maybe more medically vulnerable would be impacted by this. Of course, we know routine and structure is really important and promotes that security and safety, and a lot of that was gone. And then, like never before, there's been social and political unrest for not only the nation, but even within families. We were seeing and continue to see a lot of conflicting opinions or thoughts on the pandemic, on COVID, on politics. And so who they used to be able to just trust that if they spoke this, it is truth, both of their parents or maybe their teachers or other adult figures in their lives, they weren't able to just trust that because mom says this, but my teacher says this, or coach says this, or pastor says this. And so science and truth has been questioned and challenged like never before. And so we were all seeing these reports starting to come out, the increase in the teen mental health visits to the ER, suicidal ideations and suicide rates increasing. And then post-COVID, I almost don't think of it as post-COVID, but we're certainly getting there. And so some of these stressors continue to still be there. And then we're seeing some statistics coming out of the CDC with some of their information where they were seeing that students with poor mental health during the pandemic was increasing. You can see the 19%, almost 20% have seriously considered attempting suicide, 9% had. And then this was an important part, and this is something to keep in mind for treatment approach, is that there was significant positive correlation between feeling close to persons at school, and it was virtually or in person. They were able to get a significant number of students, and this was across the country. It was a pretty good research study that they did. And they found that regardless of whether the students were still in school in person physically, brick and mortar versus even being in a virtual type of school, that feeling connected with persons at the school improved or helped their mental health. So then we're looking at the combination, this comorbidity of substance use and mental health issues. We know that in youth, there's about a 60 to 75% prevalence having both mental health and substance use issues. And some of the most common issues that we see are major depression, anxiety, conduct disorder, oppositional defiant, ADHD, and PTSD, and using substances or alcohol potentially as an unhealthy way of coping. Oftentimes we don't know which came first, or they may have presented at the same time. But it can be really difficult to recognize the substance use in our youth when they have a mental health disorder. And so my hope is to be able to help you to better understand some of that. So this next slide is kind of done a little bit tongue in cheek when someone asks me, well, how do I know the difference? And I was like, oh, well, it's so simple. I mean, let's just put a chart together and see how different all these things are from one another. And all kidding aside, can be very challenging to do some differential diagnosing because each of these are complex. And so I just put this chart together just to, I guess, validate the challenges or the frustrations, the concerns, the confusion that you might experience, because I experience it too. I'm sitting there, just kind of scratching the side of my head going, what is this? Is it this? Is it this? Are they under the influence right now, or is this part of something else mental health wise? The symptoms here that I put in these columns, they can all be present in any of these types of situations, whether it's trauma or substance use, even withdrawal. Are they currently intoxicated, or are they withdrawing, or is this a mental health symptom? So there's lots of different ways that we can look at addiction or substance use, and so I'm going to kind of go through some of the different ways that we have come to understand addiction or substance use. NIDA, the National Institute on Drug Abuse, identifies addiction as chronic, relapsing brain disease that has compulsive drug seeking or use despite harmful consequences. And that's one of the key things that I do when I educate others, families, the teenagers, and other professionals. Is I learned this from somebody else called CUDAC, C-U-D-A-C, continued use despite adverse consequence. And that's that pivotal moment where it goes from potential experimentation to some type of mild, moderate, or severe use disorder. They are continuing to use despite an adverse consequence. Some type of significant event happens and they continue, as opposed to trying it a couple times and going, ooh, I didn't like the way I felt, or I didn't like that consequence, I'm not going to do that again. That they continue to use. It's considered a brain disease because drugs change the brain. They know that the structures within the brain do change and that they're long lasting. So this is a formula here on the left that from some time when I was working in Illinois and Iowa, before coming back home to Arkansas, I got a lot of great opportunities to work with individuals in outpatient, residential detox, and hospital-based. And this was a formula that we kind of, as a team of staff and doing a lot of trainings, came to say is the formula for increasing risk for addiction. So we've all just agreed we're gonna claim this as our own. So I'm sharing it with you guys today with a lot of other people's ideas involved in this. Accessibility, meaning how accessible is the substance? Think about a family, that has substances already in the home, or they have friends that have easy access to alcohol or drugs. Plus acceptability, how acceptable is using alcohol or drugs in their environment, whether that's at home or at friends or their school or their group of people. Plus predisposing factors. Those predisposing factors are going to be the biology, the genetics, any mental health disorders that they may have. Plus stress entered in that time frame or trauma is going to increase that risk for addiction. And so this graph over here on the right that has risk factors, this is an image that NIDA uses, and it's very much the same kind of concept as the formula on the left. Is that biology and genes are interacting, with the environment. They introduce drugs into the situation, and the brain is going to respond differently with different people. We know that there's increased risk for addiction with someone who has mental health disorders in their family. And so this is just kind of a way of helping to explain this to families of how did this come to be something that went from just some substance use to abuse. And I think it's really important to be able to help them understand this isn't a moral issue. This is a medical issue. And we would, the same as someone that's recently been diagnosed with diabetes, would want to educate them on that and how to treat it, but also prepare them that there are going to be some ups and downs. There's going to be days where you're feeling great. There's going to be days where your medication's working, your nutrition is great, your exercise and sleep is wonderful. And then there's going to be days where you just fall off the wagon and Halloween candy starts to be too much, and so you have some issues with leveling out your blood sugars. And so we want to educate them on the ups and downs, but we also want to educate them on the organs that's impacted with this. And so the brain is what's impacted by the substance use. And so we know in adolescence that prefrontal cortex is doing the most of its growth during that adolescent, teenage, and early adulthood. And so I like to really explain this as the gas and the brake system. And I'm assuming here that you guys understand most of this, but bear with me for those of you that don't. I want to make sure that you can understand it a little bit and then do some of your own research into this more. But understanding the brain and the addiction is really important for educating your teenagers that you're working with, as well as their family. So when the midbrain, being where the pleasure center is, that is the gas pedal, and that is where the survival skills come into play. That I'm going to not be thinking about anything else but getting that dopamine fix. And so acting or engaging in certain behaviors. They actually have found in research that the dopamine release starts in the behaviors or the thinking of the substances, not when the substance is actually in the body, that it's the leading up to behaviors that we start to see that flood of the dopamine. And it becomes a really challenging, vicious cycle where the dopamine levels start to be lower and lower because they've built such a tolerance to it. And that's where you start to see them seeking a high that they can't ever get again because the body starts to adjust and rebalance itself. So we start to see the midbrain and all of that impulsive behavior becoming the priority, and the poor adolescent brain, just that prefrontal cortex not fully developed and firing all the time. That's where we see that higher functioning, the ability to discern good choices and consequences, impulse, memory, logic, and reasoning. That puts the brakes on that. Like, hey, Libby, I don't know that this is a great idea. Remember that last time you touched that hot oven? This isn't a great idea. And so that forebrain does some braking and starts pumping the brakes and going, not a good idea to touch the hot oven. But if in that moment, because of substance use or because of a not fully developed forebrain, my brakes don't fully function and that gas pedal continues to accelerate the limbic system saying, I want more dopamine, I want that feel good. And so that's where we start to see some of that impulse control being poor and engaging in those behaviors that are going to be harmful, like substances. So separate from brain information, I think it's very valuable for us to take a moment and look at the DSM-5 criteria for diagnosis. I'm not going to dig deep into this, but certainly if there's any questions that you guys have about, well, how do you start to ask these questions? That's something that many of the therapists that I work with or train will say, well, how do I ask this question of them without it just being awkward? And so I really encourage you to become familiar with the different criteria that are here. So using more or longer than intended. This can look different for each person, but asking them questions related to their use in terms of, well, what, did you have any kind of plan? Like, well, I was only going to, go to my friend's house and we were just going to have a couple of beers, but then it turned into doing some shots. Or I said I was only going to take these couple of pills this one weekend to help me pull an all-nighter for studying, but it turned out that I started using it more frequently. Using more or longer than intended. Desire or unsuccessful attempts to cut down is just simply asking questions related to that. Have you ever told yourself that you were going to stop or that you were going to cut back, or that you just had this wish, man, I wish I could, but I just don't follow through with it? Many times they may go and say, yes, but, and they'll start to justify it. And there really isn't a good justification that would go ahead and discount that criteria having been met if they say yes, even if it's a yes, but. Excessive time obtaining, using, or recovering. The excessive time obtaining in our younger population and earlier in my years, that was more difficult, but it's much more accessible. And so excessive time obtaining is not what I see as much anymore as it is how much time they're spending in using or recovering. But occasionally we'll see some youth that really have to get creative in planning. And so it's not that they're high for a long period of time or regular, but they're spending a lot of time planning to be able to engage in that. cravings or desire to, or urges to use. How are they doing at school or work or home? Is there obligations and commitments? Are they struggling at school? Have they stopped going to work or have no motivation to participate in activities that they had before? How are their interpersonal relationships? Have we seen any changes in the lifestyle? Recurrent use in situations who are physically hazardous. This is one that's new to DSM-5 compared to the 4, and I really appreciated that one specifically being added because we do find that our youth will put themselves into some pretty dangerous situations, and so that was nice to have that as a separate category now. And then this is that continued use despite knowledge of having some type of medical or psychological problem that may be causing or worsening this. So if you have someone that's known to have depression or ADHD, any other kind of mental health diagnosis, and you have cautioned them or their physician has cautioned them on, if you continue to drink, this is going to impact your depression or impact the efficacy of your medications, you should not drink. And they continue, then that is a separate criteria, continuing to do that despite knowing that there's a medical problem that could be worsened by it. Tolerance, and I put in here this note because many people early on will think that tolerance is meaning that they're drinking more and more, and that's not always the case because sometimes they will maintain the amount that they are using because they, for a variety of reasons, maybe access or expense or in their own minds, I'm only drinking this much and I'm never going to go beyond this amount. But the amount of the effect has diminished, that they don't get that same high or that same mellow or whatever it is that they're seeking. And so we see tolerance in that way too. So it's not always an increase in use. Sometimes it's same amount, but the effect is lessened. And then withdrawal. And many people think of withdrawal as being physical, but it's really important to know that withdrawal oftentimes is going to look like a mental or emotional withdrawal. And so it could be something that really looks like a mental health symptom, and it's in fact withdrawal. So I get this question a lot. Libby, how do I know I'm even providing co-occurring services? So these are some things that I've tried to put together to help therapists new to providing the services to ensure that what they're doing is moving them in the direction of addressing the substance use alongside mental health or trauma. So make sure that you're screening your mental health clients for possible substance use at intake, but also continue. They're not necessarily going to be forthcoming. I know that's going to come as a surprise to you guys. But we know that when we're doing those initial assessments or screenings, that they're not going to share everything. It takes time for them to build that trust and relationship with us. It sometimes even takes us time to figure out how to ask the question in a way that helps us get to the answers that we're needing to work on with them. And so consider, what part could substance abuse be playing in what I am seeing in my client? Could this be withdrawal from some type of substance? And if you know that there's substance use, then asking the question, could this be a return to use or return of some of the substance use symptoms? And just ask them. We're very fortunate with our youth that many times they're just going to be just blatantly honest with us. And so just ask them, continue to ask them about that, and think about how their mental health is impacting their recovery efforts for substance use and vice versa, and asking them those questions. Maybe they're struggling with their anxiety, and right now they've been doing great with abstaining, and alcohol or marijuana or something like that has been a way that they've coped with anxiety in the past. And so we start to see some mental health symptoms worsening, making sure that we're talking with them about, well, okay, in the past you've used these things and these things are not healthy for you and you're still working on that. So have there been some increased thoughts about using? I'm sure that there's, these tendencies to want to fall back to those things that you've used before. And we know that those things are effective in addressing anxiety or depression in the immediate, here and now. This will get rid of it, but it doesn't. 'Doesn't. 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 ' Having been in the field now for almost 20 years, I can still tell you that I do ongoing consultation. If I don't do a whole lot of direct service work at this point, but still when I do, I do consult and just kind of talking through it to make sure that I'm not missing something that could be mental health or trauma or substance use, depending on the client I'm working with. And then continuing education, and it's really important to educate yourself on withdrawal signs and use. I do have a little bit of information on that in some future slides, but it's not all inclusive. And I think even taking the time to talk with your client and ask them, what does your use look like and what does your withdrawal look like? Because it can be different. And I can't tell you the number of times I've had a mom or a dad or a guardian tell me, I just know they're using. I just know they're using. They're acting different. They're acting this way. And that teenager is sober as the day is long. And they said, Mom, Dad, guardian, grandma, grandpa, whoever, you just haven't seen me outside of being under the influence for the last 2 or 3 years. You don't know what I look like when I'm not using. And so it's helping the family and them to understand and identify what those signs are going to look like. So then, of course, my other question that I get a lot is, Libby, what's the best treatment approach? And I'm not going to tell you that one treatment approach is better than another. What I can tell you is, for the very reason I was wanting to do this training, is that the best treatment approach is when you're addressing them both concurrently and collaboratively. If you're working on the mental health and you've got somebody else doing the substance use, I can see that working and being successful if there's really good communication between the two providers. But I really think that it can be most effective when the therapist is able to address both together. There's a lot of evidence-based treatment models out there that are really good for substance use, but obviously something that's culturally competent. Substance use with our Native American population is going to look different than a population of Hispanic or Marshallese, and so making sure you understand the culture, even religious considerations, and then obviously trauma-informed or integrated or specific. I think it's really important to start early and continue conversations around stress management and self-regulation and self-talk, because that negative self-talk, just like in mental health, is really something that goes deep and takes a long time to work through in therapy. I can't emphasize enough how important it is to do some psychoeducation with them and their families on trauma, mental health, and substance use, understanding the brain and educating them, just not overwhelming them, but helping them to understand. I'm not trying to make excuses, for Jane or John. I'm just here to help you better understand how we came to be in this place today. And then helping them to develop healthy support, structure, and leisure. There's some really great research with the ACEs and protective factors, and we know that the more healthy support, structure, and leisure that they have, the more success they will have in their recovery efforts. When thinking about treatment approaches, I also think that it's SAMHSA's definition of recovery really plays a part in my approach to treatment. SAMHSA defines recovery as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And they list these 4 major dimensions that support recovery. So when you're looking at treatment, and when you're looking at a therapy session, and what you're going to be discussing with the teenager, the adolescent, the families, or other support systems, is to be looking at their health and their home, their purpose, and their community. And then I put over here on this right side of the screen, at Arisa Health, we've adopted Whole Health Institute's Circle of Health. And there in the center is helping them to identify and to name their purpose. And then around that is taking time to pause and to notice and to choose. I'm going to pause and reflect on my life. I'm going to notice what's going on. I'm going to notice what I want for myself. And then I'm going to choose. I'm going to choose an action that supports those things. And then all around there, these petals on this circle of health are just different life areas. We've seen different models of this. So I'm not going to go into each of the categories, but really focusing on these different dimensions in life areas and having not only their self-care, but them identifying their care team and their community. And so these are all things that when someone says, how do I support someone with substance use? And I say, honestly, it's probably things that you would be doing with someone with mental health issues as well, but here's a model that we use. They don't have like a real easy place to plug this in, but I have just felt that this is such an important thing that I failed to put in so many trainings or consultations with people new to working in substance use. And so I've tried over the last couple of years to always put this in here somewhere. It was just one of those things. I kind of think about recipes. My grandma has this recipe that I would try to make over and over and over again. And every time I talk to her, I'd say, well, there's this, it just doesn't taste right, or it just doesn't have this. And she's like, oh, I forgot, I sometimes put a pinch of this in. And so this is kind of one of those things where, oh, I just forgot I put a pinch of this in here. And so I finally remembered to add this to my recipe when I'm sharing with you guys. So it's addressing confidentiality from the start. That's really important. And I know that seems super obvious, but when you're working with substance use, there's just a few extra things to tag on to that conversation when you're having it. I'm sure you're all doing it, but it's really important when you're introducing yourself to the client and to the family the first time that you're not only just discussing limitations of confidentiality as it pertains to risk of harm to self or others, child abuse and elder abuse. That's kind of our big blanket statement, right? But when you're going to be specifically working with someone with substance use issues, you have to specifically talk about the limits of confidentiality, or at what point you're going to address return to use with the client, because your client is underage. If we're talking about youth here. And so when is it, if your client is Jane, she's 15 years old and she's working with you, it's really important that both she and the guardian understand from the get-go, not when it's full-fledged problem here in front of you, like, oh boy, do I tell the family now, or do I give her some opportunity? What's the family's expectation? What's your client's expectation? And so it's really important to not only educate them on the process of recovery, that, hey, sometimes mental health or substance use symptoms are going to worsen. We might uncover some unknown traumas, and there might be some triggers to some things, and things can get worse before they get better. And so if it doesn't happen, that's great. You've been prepared and we didn't have to implement it. But it's really important that we understand and discuss, when is it as a clinician that I'm going to give the client an opportunity to talk to the family about their return to use, versus you becoming the parent's spy. I make that very clear. I'm not a spy. I'm not going to, have the parents, asking me to look into those things and then just report back to them. That I've got to be able to build that trusting relationship with both of them. How long will you allow the client to process and then tell the parents before you do? This one usually turns into some good conversation, so you might have some thoughts on that at the end here. Do you base it on use? Do you base it on how serious the drug is? Like, well, I'm air quoting here, you can't see me, it's just marijuana, versus, they're drinking a fifth of vodka every night. Do I let them continue smoking marijuana without telling parents longer than I would wait to tell them about their child's alcohol use? Are there any others that need to be notified? So it's kind of coming up with these game plans fairly early in this process of what's the expectation of who is included when, there's these concerns. And then this one's always a favorite, and I'm sure this is something that happens in all kinds of therapy with working with adolescents. But what do you do with information that the parents tell you when you you're into the day and the voicemail light is flashing and you listen to the voice message and it's mom saying, don't tell Johnny I told you, but I know he's starting to date this person and I really don't like that. And I think that she's not any good for him, so on and so forth. What are you going to do with that information? I like to have that conversation very early on, both with mom and the client, to explain, Mom, if you are leaving me this kind of information, this is what I'm going to do with it. This is how I'm going to handle that information. And I'm not going to tell you what's right, wrong, or indifferent on that. I just really encourage you to, the best place to be is not in the middle of those dynamics. And if you start to find yourself in the middle, it may be that we need to revisit this confidentiality or boundaries or expectations that are not spoken and unmet. So warning signs of use. I told you guys I was going to put some things in here just to kind of get you started in the conversation and looking into this yourself. So if you're like, oh, I wasn't aware of that, then that's a place for you to continue to find some more training on. There can be lots of different things for signs of use. They can see an increase in arguing, missing appointments or meetings of some kind, returning to old playgrounds, just those places that we've said, we've set the limit. You're not going to be hanging out with this person anymore. You're not going to be going to this particular place or house anymore. There's increased isolation. There's changes in their eating or sleeping. You might see an attitude of change, more confident, less tolerant to frustration or stress, more angry or frustrated. You might see some feelings or mood changes, and you might see some changes in thinking. And these can all look like a teenager without any mental health or substance use issues or without any trauma. And this could definitely be warning signs or symptoms of some mental health issues or some trauma, right? So it makes it really challenging and important to ask the questions. So this would be where we have some group discussion, but I'm hoping that you guys will have those for us at the end when we can. Some complicating factors for recovery, things that I hope that we can have conversation about a little bit, or I can answer for you. What I do when family members use or they're supportive of use. That one is really hard, but I think that we run into that with any kind of therapy that we're doing with a client, even with mental health issues, is talking to them about you are your own person. And yes, it can be challenging. Now, there might be some reporting that has to be done. DHS involvement may need to be there, and that's where consultation and supervision comes into play. But we often see our family members are not healthy either. Substance use or not, I think that we would continue to have the same conversations we would have with clients with mental health issues of your family member, is unhealthy too, and that doesn't mean that you have to make that same decision. And who are some other people in your life that are supportive of the changes that you are making? And there may be some difficult conversations to be had about living in a different place for a period of time, or discussing with the parent separately about that other person's use and how that's impacting their efforts. Because many times we'll see parents that'll say, yes, I know I smoke cigarettes and I keep telling you it's bad for you and I don't want you to do it. Do as I say, not as I do, kind of thing. And that's still a very difficult situation. When you have somebody that's resistant to treatment, they're minimizing or they're denying the problem, that can really complicate factors things as well. And what I would say is that if they're willing to show up, continue to build the relationship and the rapport, and just use whatever model you're using, whether it's motivational interviewing, brief solution focused, any of those that are going to continue to help you work through that, because that resistance just takes time, and using the relationship that you're building to work through those things, using the psychoeducation and educating them. It's not about arguing with them about the research that they might find that says that marijuana isn't bad for them. It's helping them to understand the research that you know about how it's affecting them, and say, well, would you be willing to delay your use for right now? Because would you agree that your brain, the research shows the brain is not fully developed? So there's different ways, depending on how old they are, and the level of resistance that you can work with that instead of trying to push against it. If they're needing more intensive services, that's important that you're having those conversations. I usually set this, if I'm anticipating that that might be the direction I'm going to have to go, if I know, okay, I'm going to attempt some outpatient, but I'm not really sure that, you know, once a week is going to be frequently enough, or every other week. And I know that's really hard for you guys to get him here for these appointments, and I'm willing to try that. But if that's not going to be successful, then I'll have that conversation with you. So it's important to have those conversations as well. Like I said, coming up with a plan for if there's return to use, having that recovery plan in place, or an action plan for how you and the family are going to respond to it. A return or worsening of mental health or trauma symptoms, really closely keep an eye on the potential for substance use, or whether or not substance use is present. Any one of these can make this extremely challenging, and you know, there's not a lot of great resources when it comes to needing more intensive services for our adolescents in the state. And so having those conversations can be really difficult when there's not an easy place to point the family to when they need those more intensive services. And then this one is, I know, kind of a repeat, but my clients return to use, now what? And so I want to kind of go through all of these. When or how are the parents informed? That's part of that confidentiality, early discussion stuff. Assessing, is it appropriate for them to continue at this current level of care, or say it's just no longer appropriate, ethical for me to continue to see them at this level of care. The importance of educating them on the disease, like I mentioned, that recovery plan or wellness plan. And then when you're reviewing that process of return to use, there's so much focus on the use itself, but it's really important in order for you to disrupt that pattern. Because remember, I mentioned at the beginning that the brain starts releasing dopamine before the substance is even entering into the body. And so it's disrupting that pattern of behavior that they have developed. And it's really important to break down and go through, well, when did you start to see a change in the attitude or the thoughts or the feelings and the behaviors that were leading up to the use? Because the return to use and that relapse is not a moment in time. It is a timeline, and it is a process leading up to that use again. And so we really want to help break that apart and be able to disrupt that earlier and earlier the next time. So then the next time you start to notice a change in your attitude, or you start to hang out with a particular person again, those become earlier and earlier warning signs for you and for their family. And then I really encourage and know that this can be very challenging for a variety of reasons, but getting or keeping the family or other supports involved if there's return to use, but definitely knowing, like I mentioned in those earlier slides, who are your people, who need to be notified, what would be the plan if something happens, who all needs to be involved to wrap around this person to help them. And then this is my last slide here. I just cannot do this without ending with recovery as possible, and that we need to, normalize that this process is one that has highs and lows, ups and downs, winding road in the recovery from their trauma. There's so much work to be done, and that can be so challenging to do sober if they have been using substances to help them with the coping. Relapse rates for people treated for substance use disorders are compared with those for people treated for high blood pressure and asthma. And relapse is common and similar across all of them. So we need to treat them like any other illness. And so I have this graphic. I have seen one like this before. There's this imaging of a brain, and we can see all the different highlighted colors of a healthy person there in the center of their brain. And then in the center is showing someone who had been using meth and had about 1 month of abstinence. We see there's not as much of those reds and deep oranges as we would see for somebody with a healthy brain. We're already starting to see some healing happening and some increased activity in those parts of the brain. And then when we look at that person 14 months later, we start to see some additional healing has happened. And so that's a really important thing to know, is that this, yes, it's going to be a different brain, it's a different process, it's altered, but it's also able to heal. And so over here on that other graph is just showing some of the relapse rates for different things. So that first one is substance use disorders. The relapse rate is 40 to 60% for that chronic illness. Hypertension has relapse rates of 50 to 70%, as does asthma. So it's just helping them to understand. The biggest issue that people have is there's so much more stigma related to substance use, that the consequences of someone's asthma or hypertension doesn't necessarily impact so many people around them. But I think it's really still important to talk about that recovery piece, and that there is a very good success rate for those that are engaged in treatment and have that support around them. I've got my references there, and then my contact information. And I thank you guys so much. Do we have any questions or anything at the time we have?
Yeah.
Comments. If anybody has anything to add, please. Like I said, I know there's going to be some other, experts in the room, more so than me, and I welcome that. Like I said, I want to be the host of some good conversation.
Absolutely. That was a really great presentation, Libby. We had a few questions come in. One person wants to know if there's any benefit to becoming a licensed alcohol and drug addiction counselor. They're already an LPC, so if you wanted to also do that, is there a benefit to that, and what would be the process for that?
I do get that question a lot. So I didn't share any of my background, but I have other certifications that I have just not maintained, and so there's a couple of different options in the state of Arkansas. So I started my career in 2004 in a different state, and then I moved back home. I'm originally from Arkansas. I moved back home in 2011 and wasn't really familiar with the processes here, and so I was just kind of like trying to figure my way. So I have the LADAC, the license. There's also certification. I don't know, I think they call it KDAC here. I've been back for 10 years and I still hear it called different things. But there's a certification for drug and alcohol counseling, and there's licensure. I wouldn't feel comfortable in saying one is better than the other for a person, but I will say look into both of those. And in terms of, I think just with other things, you can become a licensed family marriage therapist, and you can also be an LPC, right? You can do the same things, but one really signifies that you're an expert in family and marriage. And so I think that with the substance abuse credentials, it's a similar thing, that you can really identify yourself and stand out as an addictions professional. I like the standards that they have in terms of some accountability and access to a group of people that are professionals in the field, that you can go, oh, okay, you're a LADAC, or okay, you're a KDAC, and I want to learn some more, and they can point you in the direction. But I really am impressed with some of the expectations of education supervision, and so I would encourage you guys to look into that, anybody that's doing that. In terms of like reimbursement, to my understanding, there isn't anything at this point that would give a higher rate of reimbursement for anybody that's billing third party. But that certainly, if you're in a private practice, I suppose you could opt to increase rates or something like that if you were that way. So I don't know if anybody had any other specific reasons they were asking in terms of benefits that maybe I didn't touch on, but in terms of just it's enhancing your skill level and letting people know. You don't have to have it to practice and provide substance use treatment.
Helpful. Someone else wants to know why we don't have enough rehab services for adolescents in our state.
Can you say that again? I couldn't hear you very well.
They wanted to know why we don't have enough rehab services for adolescents, such as a 28-day program or longer for adolescents.
Yeah, that's a great question. When you find out the answer, let me know. Um, I don't know. I think that's probably a lot of different, there's a lot of different reasons for that. Um, it takes being in the treatment field. I can tell you, having opened many residential treatment centers in different states, as well as some of the efforts that Arissa has done with residential, it takes a lot of financial resources to do that. The licensure standards, you want, these are our children. We want a good facility. We need well-trained staff, and that costs a lot of money. And I hate to talk money, but I think the rate of reimbursement is probably a factor in being able to do that. But I think that there's a lot of dynamics that plays into that, and I don't think anybody would question the need.
Right. Absolutely. What are some, you kind of touched on or mentioned a few evidence-based models for treating substance use in adolescents. What are some kind of the gold standards, or what are the treatment models that you see are most effective?
I think the most effective are going to be the ones that the therapist is most comfortable in, first of all. If it's a great treatment model, but it's not one that you feel comfortable in, or it's awkward for you in any way, it's not going to be as effective. I've worked with a lot of therapists over the years that have different approaches and have seen them all be successful in different ways. We know CBT to be a really great one. EMDR can be very helpful. We're very grateful to have a lot of EMDR therapists that are working in conjunction with a lot of our substance use providers. The brief solution focused practice, I think, is a really great model, as is motivational interviewing. Those are, are you going to follow it to its true fidelity, I guess would be a question, because I like to really, I hate to use the word eclectic. We all, have thrown that word around, but I think that you can be truly in any one of those models and truly following it and be really effective. And I've also seen people pulling from different ones and that also being helpful. That's why I tried to shy away so much. If you notice in my topics, I didn't really just hone in on one particular one, but rather saying the important key things. I think regardless of the model that you use, that if you're screening, if you're asking some of these questions, aware of the warning signs, you're keeping the family involved, you're working through self-regulation, stress management, and building supports, those I think would be supported by any of those evidence-based models.
One last question, and then I'll share with everybody about how to get your CEU. The last question is, how do you talk to teenagers who come to you curious about getting a medical marijuana card to manage their trauma or mental health symptoms?
Carefully. Carefully. Well, first of all, they may mention it to us, but I'm not someone that can actually get that approved for them. So that they usually just kind of talk about it in passing. I haven't had anybody that's really, trying to get me to convince them one way or the other. But what I would say in that, I don't know that that is a first step. It's kind. I don't want to. I use a lot of analogies and things like that, and this one may not be the greatest one to use, but it's like, we have a hangnail and we're going to go ahead and cut the finger off. That it's not really the first step in addressing this. And so when all other things are not working that we know to be effective, because there's just so much controversy around it, and the research is not there yet to really support that being the best for the most people. I'm not going to say that it couldn't be effective for somebody, but I don't really know that that's going to be the most effective. And so let's rule out all these other things that are tried and true first.
Well, thank you again, Libby, and thank you everyone for participating. That's all the time we have, so I'm sorry if we didn't get to your question. The CEU code is 2510. I will be sending an email out to all participants with a link to a survey that you can fill out and put the code in. and then that will get you your CEU certificate. And I'll also include a copy of the slides from this webinar in there if you're interested. So stay tuned for that here in the next few minutes. And thank you. Have a wonderful afternoon.